Well, perhaps while we're waiting, I'd ask Dr. Pegram to comment on a couple of issues. So we'd heard from the lung cancer talks that there are perhaps better biomarkers than PD-L1 expression. Has that been looked at in any of the studies that you mentioned?
Probably the most dense coverage for biomarker work in breast cancer for checkpoint inhibitors is the I-SPY program at UCSF. They have a very broad portfolio of markers that they're looking at. I haven't seen the results per se yet, but I think they're still being analyzed and should be forthcoming. The other advantage, in my view, of the neoadjuvant approach as a experimental laboratory for elucidation of biomarkers is you have both pre and post-treatment samples available, which is a huge important consideration in the context of immune therapies where the effector cells can be in different populations. Sometimes they're in the circulation and sometimes they're in the tumor microenvironment, and the trafficking from one compartment to the other might be critical, and it might be highly dynamic before and following treatment. So it may well be that the most important biomarker could be a post-treatment effect, for example.
Mm-hmm.
So the neoadjuvant designs are most well suited to answer that question.
Okay, thank you.
So I have a couple of questions, one for Dr. Pegram. So with MSI high solid tumor, now we have pembrolizumab approved. What kind of role do you see for MSI testing?
Well, I mean, that's a very good question, because certainly there are unstable genomes in subsets of breast cancers, and the label language for the Pembro approval was pretty broad. And so it does raise this as a possibility. The other question is, my recollection of the label didn't specify the assay methodology for determination of such instability. And so you could kind of push the envelope if you wanted, if you had some assay methodology, even an experimental one, that said a patient might in theory benefit from a checkpoint inhibition approach. You could probably do a peer-to-peer argument with the payer and try to get it across the line for insurance coverage. I don't know how that's going to unfold and how well received that will be, but the label is not very concise in terms of giving us any direction. So I suspect some people will try it off-label. Better to put them on a trial, I think, and those trials are ongoing in all stages of breast cancer. The pivotal phase 3 metastatic trials are ongoing, as are these neoadjuvant efforts that I've shown you today.
Sure. Now, if I have a stage 4 breast cancer patient who is responding to one systemic therapy, and 3 months later, if the patient has one spot increasing in size, do you think radiation therapy in that particular patient would be useful?
And where is this spot?
For example, there is one new spot in the lung, or one lymph gland that is enlarged.
Yeah.
However, all other spots are stable.
Yeah. So we've actually been approaching stage 4 disease very differently over the last couple of years, and especially with the techniques of radiotherapy can be much more targeted. So we're doing, stereotactic body radiotherapy to lesions in the liver or the lung, or as you mentioned, the axilla or the supraclava nodal recurrence in the mediastinum. So we have been working with our colleagues, and if there is stable disease and they're looking good performance status-wise, then we will offer it to them. And of course, explaining to them that we're not likely in that situation to impact their survival, but rather their disease control, which I think is a meaningful endpoint to a lot of these patients.
As a follow-up, I'd like to highlight results from a paper that was presented at ASCO this year by the group at MD Anderson in a collaboration with the Yale investigators in the context of HER2-positive oligometastatic disease. And in those cases, if they were able to achieve a complete clinical response with stage 4 disease, they had literally no events with long follow-up for the clinical CRs. So if you need to use another modality to achieve that CR on a HER2-positive patient in the context of HER2-targeted therapy, based on that data, it would be pretty compelling to give it a try, and at least at a shot at curative intent.
Right. Well, that's what they're advocating at ASCO. Try that. So. However, there's no good data apparently.
Another question for Dr. Pegram then, if you don't mind. So in the old days of endocrine therapy, if someone was progressing on, say, an AI, we might go to fulvestrant as the next line. So now if we're treating people with, say, letrozole, palbociclib, and they progress, is there reason to think about still using a combination?
I'm torn with regard to the answer to that question, especially after the San Antonio meeting this past year. Typically, the guidelines would suggest, probably move to fulvestrant as a single agent following progression on a CDK4/6 AI combination. But at San Antonio, we saw the randomized trial called 0102, which was fulvestrant with or without an mTOR inhibitor. And that was a positive study. And so that might be on the table for let's say, a Palbo AI progressor. It's either going to be fulvestrant or fulvestrant plus everolimus based on that data, in my opinion. Now, that data was not post-CDK4/6, I'll grant you that, but it's level 1 evidence on a randomized phase 3 trial that the combination of mTOR inhibitor with a selective estrogen receptor degrading agent is superior to fulvestrant alone. Can't argue with data.
Yeah.
So I usually now do a balanced discussion between those two approaches, including the safety issues regarding everolimus, and then the patients often will help in that decision making.
Thank you. Okay, so maybe a final question for Dr. Horst. Given the data that you showed with the improvement in both disease-free survival and overall survival with radiation to the lymph nodes, et cetera, do you think Halsted might have been right after all?
Well, since Halsted was a surgeon, I think that I think there's something with the radiation, and that's the thing. As I was saying, I think that we're probably attacking some micrometastatic disease that's not radiographically evident, but with better systemic control and getting in radiation, I'm thinking that the local therapy is really, it is making a difference long term, which is different than some of the other diseases where the systemic control is still outweighing any benefit you might have with radiation.
Fair enough. Well, thank you both very much.
Please complete your evaluation. That is going to help us tremendously in planning our next meeting. And it is critical that we have it for our CME purposes. Now we have almost 20 minutes break. Our very exciting session on immunotherapy. As you know, it's all about immunotherapy. And that is coming at 4 o'clock by 2 experts. We have David Maloney from SCCA and Wally from Utah. So I'll see you back at 4 o'clock. Thank you.